So first of all, welcome everyone. Welcome to our public governing body. Although we haven't got any members of the public actually observing, we are recording this from start to finish, and we will make it available to the general public. And so please be cognizant of that with the language that you use, to make sure that it's something that can be understood by the public, and also as I'm sure we always are, with the way that we conduct ourselves within this meeting to demonstrate the values that we have as a CCG. We often check whether there are any questions. We have not had any questions raised particularly for the governing body, so we don't need to bring any of those in. Can I draw people's attention to the declaration of interest? And if I do overall page 5 onwards, can those members of the governing body please highlight whether there are any alterations or additions needed to be made within those declarations of interest? So no hands, so I take that as read. And any declarations that people need to make that are pertinent to any agenda items that we have within our government, within the agenda. Charlotte.
Yeah, Paul, I just wanted to flag my involvement as an associate for AHSN and their work supporting the Think 111.
Okay, all right, thank you. So when we get onto that, we will bear that in mind. That's very helpful. Thank you.
In addition, Nelly said Kevin could start in a minute if that's helpful while we wait for Lena. Given also that the patient story today is about the Devon ethical framework, so it might be useful if that came before Susan.
Yes. Okay, well, let's run them two sequentially. So let's just quickly go through the minutes, get those out of the way, and then we can go straight from the patient experience story item straight into the ethical framework, and they will flow quite nicely then. That sounds like a good idea, Charlotte. So can I just take people through the minutes of the last public meeting, which was from the 18th of June, and I'm just going to ask people for points of accuracy, anything that people would like to highlight. Then I will take them as read as an accurate reflection of our discussions. And the action log, I think there was just one action that was raised as a result, and this was in response. I think Simon Kerr, you raised concern about the difference in death rates for Devon compared to the whole of the UK, and Simon was going to look into it. Simon's not with us, but Virginia, you are with us at the moment. You might be able to give us some insight into, and I think this was around excess deaths.
Oh, okay.
Where Devon sits with regards to excess deaths compared to other parts of England and other parts of the United Kingdom.
Yes, indeed. I'm obviously as Director of Public Health for Devon County Council. I'm only speaking about Devon County Council, but we did some analysis looking at the death rates for the county through the winter period, and compared it, so that's 2019-20, and compared it with previous years, and was much lower than the previous 5 years. So we think that may have been a combination of mild weather and probably the impact of the flu vaccine. And then we ran an analysis with the support of clinical coders from the Royal Devon and Exeter NHS Foundation Trust to look at how those death rates were changing from the 1st of January through the period of the first peak of COVID-19. And although, like everywhere else in the country, we saw a peak, the peak in Devon was much less. And although it was significantly higher than we would have expected, when you looked at what we'd experienced in the previous 5 years, it actually didn't look that bad and reverted to normal death rates within about a week or two. So we saw although we did have some excess deaths, some due to COVID and some due to non-COVID conditions. So that's people, for example, with lung conditions or heart conditions. The actual impact on the population was very much smaller than the rest of the country. So it's another example of where Devon actually fared quite well in comparison.
Paul, you're on mute.
There we go. There's I will donate to charity for having got that one wrong yet again. Sonia has just forwarded me some figures that Simon Chant from your team, Virginia, worked on one with us to look at Devon's death rates per 100,000 for COVID-19, and we were much lower than England, and certainly much lower than other areas within the United Kingdom. So hopefully, Simon Kerr, that's both what Virginia said, and I'll make sure these numbers are circulated to governing body members, so that's reassuring. And I noticed that it's currently on BBC News now that England is being viewed as having the highest level of excess deaths, but it's helpful to know that Devon actually is on the lower side of that compared to the rest of the country. Thank you. Well then, in which case, Charlotte, can I hand over to you, because you've got some people who, from a public and patient perspective, have been involved in the process and the engagement around development of this ethical framework. So over to you. Thank you very much.
Thanks, Paul. Yes, I'd like to welcome Kevin Dixon, and is Vina Flores here yet? Nellie? No.
Not that I can see, no.
Well, we'll start off with Kevin, and really what I sort of want to highlight and thank the engagement team for sort of bringing this idea forward is to give the opportunity to listen to Kevin and his experience of being involved in the development of the framework, but also from the engagement team's point of view to highlight how valuable it was for them to be asked to be involved at the very beginning around the engagement process, rather than perhaps sometimes getting involved later on when things are more developed. So perhaps a good example of how to sort of co-design from the beginning, and we can obviously discuss that more later, but I'll leave the time for Kevin and then any questions to Kevin and Nellie when Kevin's had an opportunity to speak.
Well, yes, thanks very much for the opportunity, everybody. For folks who don't know me, my name's Kevin Dixon. I'm I'm a volunteer, I'm a carer, and I also chair Healthwatch in Torbay, and I'm linked up with the patient participation networks across the whole of Devon. I mentioned the care a bit because my mum's got Parkinson's and she's next door having a bit of a lie down. She's 89. The other reason I mentioned that one is that I think it's 3 weeks ago, and it was midnight on a Sunday, that she suddenly came in convinced she was having a stroke, so I had to sort of rush her off to Torbay Hospital. So I got a bit of experience and about that one, and sat there for 4 hours outside with a very vulnerable elderly person actually in the hospital, but I wasn't actually allowed to access her, so that's one of the issues. Let's see, I was invited by the CCG, so thanks Nellie for thinking of me, to come along and facilitate 3 Zoom Teams groups, one of which was elderly residents, the other one was BAME residents, and the third was folks with disabilities. And it was an extremely sort of productive discussions. I think we went on for an hour and a half, 2 hours, something like that. And so within 3 weeks, I think we, the CCG, managed to pull, with the help of Healthwatch and other patient organisations, managed to pull together, I think, of sort of fairly representative groups from those 3 target groups. So within 2 or 3 weeks, we had those meetings, and it was just really. I think we started off by having a sort of fairly tight agenda, just asking particular questions, what they thought about the ethical framework. But it opened up into much larger conversations about co-design and co-delivery. So I think it was very productive. and I was hoping Vina was going to be here to sort of talk about from the BAME experience.
She's just arrived.
joined.
Oh, Vina is there, brilliant. I'll give her a second to get into the conversation. But so I thought it was extremely good. We talked about code delivery, we talked about code design, but it was much wider conversations. And I think we've established a principle that we can get folks together. And one of the things we've had in the past, we've had lots of engagement groups, but they've often concentrated on, I don't know, on Torquay or Exeter or Plymouth. And this is a way using technology and using those Zoom and Teams approaches where we can engaging people in your Appledores and your Tavistocks, and so it brings in that rural community. So I think it's a good example of setting a precedent. I think communities want to be involved, they expect to be involved, and one of the things with COVID, I think it's accelerated the things that we've been banging on about for years, really, about engagement, about involving patients and empowering patients. And it's a bit of a tribute to the CCG and elected members and officers that I think we've made tremendous moves forward. And if I'll lead straight into Vina if you're there. I can't see you, but you're there somewhere.
But I think you might be on mute. Oh, there you go.
Yes, I am now. Hello.
Hi,
Good afternoon. I'm sorry, I'm late, I think. Yes. Yeah. Hello. Can you hear me?
Hi, Vina.
Yes, we can hear you. Yeah, well.
Yes. Yeah. I was invited by Nelly to give some feedback about the framework that we have done, and I managed to get in at least. Anyway, based from my experience during the consultation, definitely it was really helpful and really a great privilege for me and for my client, because they felt that they are being heard, their voices are being heard, because obviously, when you are a foreigner in a country, they felt the confidence is missing. So that is one thing that they felt they are part of it. They are involved in such consultation. Hello? Yeah.
Thanks,
Yes.
Vina. Yeah, that's great.
And yeah. Yes. And also what I've noticed as well with my clients, because of language issue or barrier, they tend to really don't come and ask for help unless you would come and ask them directly or do some consultation. What we did, that is their opportunity to open up. So it's really, really helpful, and I think it would be good if we can do it regularly in a way to be able to always hear their voices and let them feel that they are part of the community.
Thank you very much. Thank you, Vina. And Kevin, any questions? While people think of questions, can I start one off? Because this was about a particular issue that we felt it was really important that we engage with you. Often we decide the things that we need to talk to people about, whereas there may be something about actually you determining what are the important things that you want to hear about. Do you feel that you have an opportunity to inform our decisions about who and when to engage, or do you feel that actually we come to you when we've made a decision that that's the right thing to do? And if it's the latter, should we be moving to the former, and how might we do that, do you think?
Yep, so I'll come in just to say that, Paul. Yeah, I think it's a process, and I think we're actually getting there. And I mean, linking up with the patient participation groups and all of those other engaging possibilities and opportunities. I think in the past it has very much been, here's the policy and what do you think about it? I think now we're developing those kind of networks. So I think we're certainly getting there, and I think we've proved it. So I think this was very much an experiment about engagement, right from the beginning. But I think anyway, I'll let Vina come in.
Yeah, yeah. Engagement is really important. That's what our organization actually, to help these people be engaged or be part. That's why now I can commit with Nelly, because we are doing lots of activities like weekly arts and family activity, which is online. So this is a good thing for them to be engaged with the children, like a family bonding. So we always do that on every Thursday weekly, and the exercises. So it's really for them. I think it's very important to be engaged because they tend to feel isolated. And isolated because of confidence, and they are not so aware of the services that we can provide, that is open for them, that is available for them, something like that. So it's really like letting them be aware that you're all working for them, that they are part of it actually, for everyone.
Thank you. Judy, you've got a question.
Yes, thank you very much, Kevin and Veena. That was very interesting to hear, and I'm glad we did something where we engaged you initially. That's lovely. This might be more a question for Kevin than for Veena, I'm not sure. How good are we at coming back to you afterwards when you've been engaged in a policy and you've given your opinions or your group of people you engage? Do you have a sense that you get to know afterwards what happens, or is this something we need to work on too?
I think it's something that needs to be developed. And one of the worst things about engagement is we go out and talk to, I don't know, 1,000 people or something, and then we sort of feed it into the CCG or the local authority or pub, whatever, and then something major happens, and then you don't tell us that you've done it. And the two things that we like doing is gathering, harvesting the information and the needs of the communities, and then feeding it in, and we just need to go back and tell people, this is what you said and this is what happened. So I think that's absolutely crucial. Now with the sort of Devon-wide newspapers and that which is now in place, I think that's a really useful tool. I think we need to use social media a lot more. We'll go to where people are rather than where we expect them to be, and just put it in terms that people understand. I mean, a few years ago, I think we did something on learning disability nurses and gathered the information, fed it back, and then something happened, but nobody told us that was the reason why things had changed. So there's tremendous things and tremendous positive change going on. We just need to tell us, and we'll tell everybody else if that helps.
Thank you.
Yeah, I think with our with Hikmat, actually, we always inform our clients of what has been happening, things like that. So because we have a COVID support group, so all my team, they make a phone call of once a week to all our clients and give them an update of what's happening, what's new, and then if they have some question, they would come to me, and then I would like about the organ donor. They are quite not happy with that, so they ask about to clear about it, to make a clarification about this organ donor and things like that. So it's because we have a different culture, they have different culture, the Syrian refugees and things like that. So yeah, they are really well informed, and we try to update them through WhatsApp group.
Thank you, Veena. John, bring you in, and then
lovely, thank you. So Veena and Kevin, you're both very welcome, and thank you for what you've been saying. And picking up Kevin there, you use the term, you talk to thousands. So obviously both of you have your personal views and representative view, which is so important, because we all live very different lives. And in some ways, my question is actually for Andrew Millward. When we talk about engagement, and when I looked at the Virtual Voices panel responses, am I right in thinking that we contacted the whole panel, which is 1,700 people, and then we got only 53 responses? Because if that's the case, it's a bit disappointing. And do we need to look at how we make that panel maybe more effective and have a stronger voice and encourage increased use, and whether we can ask Veena and Kevin, I don't know whether you're part of the panel, yeah, but how we can make that panel more effective. So Andrew, first, a very low response rate. What's happened there?
It appears to be, John, but actually, if you've got a panel of 1,700 people, of course, people will be interested in different topics, won't they? So I think actually it's about doing it in very different ways. So the work that Veena and Kevin have been helping with was extend beyond the panel. So
Yeah.
I think the panel is just one thing that we use, and we get different response rates, John, depending. So we went out and asked during coronavirus what were some of the barriers to using services, and of course, because that was a bit more of a common question, we got a lot more responses. So I think for me, John, is the more we use the panel, the more interest there will be, and I think that will escalate. But also we've got to start using other channels as well, which is part of what the work that Veena and Kevin have been supporting us with. And then I've met with Susie subsequently to talk about how we particularly can do a lot more work with our diverse communities, because I think this has been really quite exciting doing this work with Veena. I think if we can do a lot more of that, John, we'll get a whole lot more range of views.
Yes, I suppose I thought ethical framework is something that I would have thought would interest everybody if they actually understood what we're talking about.
Yeah.
So yes, I think we have some work to do to try and reach as many people as possible, and the different approaches we've taken here has obviously been very important to help inform this framework. So thanks to everybody for the work that's been done.
Simon.
Thanks, Paul. I just wanted to ask Veena, really, we're trying to modernise the way we engage with our patients in my practice, and I think a lot of other GP practices could learn that as well. And I'm trying to bring the Virtual Voices panel idea to my practice to see if we can get a representative demographic group of perhaps 100, 200 people that would be similar to the 17,000 patients I've got registered with me to do a similar type of engagement mechanism. Do you think, I did some work with ethnic minority communities through the Hikmat Centre several years ago with regard to carers, and what we learned from that was that there are certain cultural groups that really like to engage through their own community centres and not necessarily through general practice or primary care. Will we struggle to get people from different cultures involved in a virtual patients panel at practice level, do you think? And should we be approaching them more in the local community centres that they go to?
Basically, yes, I think what we do actually with our flyers, we put it in different surgery, practice or the center. But the only problem is sometimes they are not so, I would say confidence to us. That is the issue mainly because of the language barrier. Unless I've already been in touch with them, and then obviously I would ask if it's Arabic, I would be bringing interpreter with me. But we get referrals actually from the practice surgery of minorities. But it would be helpful if, like I have recently now, they signposted Hikmat, and through that, she became part of the Hikmat, and she's been taking part of our activities. So I think it's a good thing if we word of mouth, I think it would be helpful.
It may be a bit like Andrew says, we start small and then it will grow, people will get confidence to join us, and perhaps we'll get a more diverse group of people being part of our panel, because at the moment we don't have engagement with all the different people that we look after very, very well.
I think on the statistics, we have about 40,000 across Devon of minorities now. Wow. That was in 2008, so it's increasing. So I'm sure with some students as well. But family-wise, we have about 40,000 Black minority across Devon.
Okay, that's really helpful. James.
Yes, thank you. Thank you, Kevin and Veena, for that. That was really interesting. And I'm intrigued because the process kind of necessitates you using virtual meetings and bringing people together. And you mentioned reaching out to Appledore, etc., and having those voices join. But I'm kind of intrigued to know how it felt not being able to meet in person, because I think, having read the ethical framework, I'd definitely be in need of a hug in the end of an afternoon discussing it. And I'm just wondering whether you missed that. You missed actually being able to meet in person and have that interaction.
Yeah, I'll go first. Yeah, but very much so. I mean, it's been unusual. It's been difficult for other communities over the last 4 or 5 months. And we normally do outreach, and we do have these sort of engagement groups, and for anybody that does chair a group, and I know we've got Susie there who chairs groups. We've chatted about this, so you do get a lot out of those, smaller groups and the larger group meetings. And when we did the, the major engagement about reorganisation of cottage hospitals a few years ago, those large groups are really quite interesting. But there's disadvantages, as certainly as well. I just think that the technology has moved on. I just think it gives us a lot of opportunities, but it's not a solution to everything. So that face-to-face socializing opportunity I think is really useful. So it's not one or the other, and if we do get back to normal, whatever that is, then I think we'll be doing a lot more sort of face-to-face mutual support. And just going back to that earlier point about being quite a complex issue, I think John mentioned that, and actually, and I think you engage people very generally, actually let them set the agenda, and then you can sort of gently bring in things like the ethical framework, and once you've got people's confidence, and it's much easier to do that face to face, I think, in sort of larger community settings. Go to where people are rather than where we'd like them to be, I think, my suggestion.
Can I say something?
Yes, of course.
Yeah, I think most of my clients really miss seeing their doctors, their GP doctors, actually, because it's totally different, even though the language is already a problem, and then when you are on a virtual or on a phone, it's so hard for them all the more. So they all really miss seeing their practice doctor. And also, especially when you are so upset, like a domestic abuse victim, it's different when you are face to face, I think. Yeah, we miss all of those. My clients are. Yeah.
And I think that's really important. There's a number of GPs who are in this meeting at the moment, and we do have that discussion about getting that balance right, so that you can do the face-to-face or as near to it as is possible to try and meet people's needs whilst keeping everyone safe and doing what we can remotely. And I think it'll take a while for us to find the right balance there. But I think your views and people missing some of that face-to-face, particularly if their communication challenges are greater than others. Just if I can, I was part of one of these virtual engagement panels, and I have to say there is something, although it's not ideal if you're not meeting face to face, the advantage of having a GP, a care of the elderly physician from Exeter, an intensive care specialist from Plymouth, and some people whose background is in ethics and have that national expertise, all being able to engage with you and listen to you, and for you to hear from them in one meeting is really something that we've never had the opportunity of before. So I think there are opportunities that come with this, albeit with that with that loss of that face-to-face social interaction that you get. So it was a hugely valuable experience that I was part of. So so thank you, Kevin, for helping getting all of that organised. Thank you both. I'm certain, and I will see Andrew nod, I'm sure that this won't be the last time that we will be having discussions with both of you, and hopefully we will be engaging on things that aren't surrounded by COVID at some point, and who knows, in person one day soon. Thank you both.
Thank you very much. Thank you.
So let's go straight on to then item 7, which Susie has joined us for. So I assume most people know Susie, but Susie, I'll get you to introduce yourself in a minute. But you're the independent chair of the Devon STP, and right at the beginning of COVID, you agreed to set up an ethical reference group for the system to support the organisation's own ethical governance structures, and also to look at some of those key system ethical considerations. And I have to say, you got a stellar cast together to form that group from across the country, which was fantastic to have such expertise available. And one of the key outputs from that group is the Devon Ethical Framework and the guidance on the allocation and withdrawal of treatment, which is what you're bringing to us now. And we've got 5 recommendations, including 2 approvals that you're bringing to this governing body. So thank you, and I will hand you the floor. You might be on mute, Susie. You are.
Okay. I do pay the money to the charity. Thank you very much indeed. Sorry. Now you can all hear me. I'm absolutely delighted to be here to present the papers, but more importantly, I want to thank Paul and you, the CCG, for deciding that it was important that the system in Devon had an ethical committee across the whole system, and B, to have had the confidence and courage to do the kind of public engagement that we've done on this piece of work, because I think some other organisations would have bottled it, frankly. And the fact that we did such important work and we got so much from it, and we undoubtedly made the guidance much better through doing it, and have set up some really valuable relationships through doing it, and I think set some precedents for doing our public engagement rather differently perhaps in the future. That's all a tribute to your approach, so thank you so much for that. So one of the tasks of the Devon Ethical Reference Group was to bring some commonality to the ethical positions of organisations within the Devon health and social care system, and to fill in any gaps where we could identify that there wasn't national guidance, so that our clinicians and patients would have the guidance that you would expect and was needed. And it was obvious from very early on that although different organisations within our health and social care system, of course, have their own statutory authority, have their own statutory responsibilities, nevertheless, in order to prevent postcode lotteries and to work effectively as one system, there needed to be a common ethical approach. And I think that the need for a common ethical approach was perhaps nowhere more crucial than in this area of allocation and withdrawal of critical care. And you have in front of you for approval 2 papers from the reference group. One is an ethical framework, and secondly is specific guidance on the allocation and withdrawal of critical care. I believe that last month you saw the legal and procedural advice from David Locke QC, and in keeping with that advice, we conducted public engagement on these documents. So we used the Virtual Voices panel, as you've heard. We convened 3 special focus groups, BAME communities, people living with disabilities and older people, specially chosen because we recognise that the evidence, of course, on COVID morbidity and mortality evidence is showing that those are all people who might feel reasonably this guidance would apply particularly to their situations. And then we also had a webinar through which we gave the documents another public airing. And if you're able to watch that webinar, I think you'd find that very interesting. So through this public engagement, we heard back some very valuable reflections and comments and suggestions for making improvements. And Paul has alluded to the fact that we had a really good committee in the first place, and that is absolutely true. I mean, we've got some of the leading national independent people on it, and we've got representatives from Healthwatch, from Equality and Diversity, and from clinical representatives of all the different trusts. But nevertheless, as I said in one of the introductions to the focus groups, it doesn't matter how good a group of people getting around a table are, there's always something you don't think about, or there's an aspect that you need to look at it through in a different way. And it was extraordinarily rich to have this public engagement. I think that in doing this and doing it as well as we have done, this should give you considerable comfort that although the situations we are thinking about, specifically the situation of having more demand for critical care facility than exists. Although that is a really difficult thing to think about. And I, hand on heart, don't think actually that we're ever going to be in that situation in Devon. Nevertheless, we know that other parts of the world have faced that situation, are facing it today. And I think that it behoves us to be prepared. We shouldn't leave our clinicians at the front line unguided, I think. So we now have a common approach which has been worked up very carefully. And we have tested that through public scrutiny. I think in doing it this way, I truly believe that we are best in class on this. Some of the independents who are sitting on the ethical reference group have told us that this is absolute cutting edge best way of doing it. And that nationally organisations could learn from how Devon has done it. So I just think this reflects incredibly well on the CCG and shows us what we ought to be doing for the future. I just want to refer lastly to the point, James, that you made about how was it doing it remotely, and if you'd been, you read through it and you felt you needed a hug, and acknowledge, as we did going through the process, that this is very difficult stuff. Well, what I learned from this is that if you can do something as difficult as this, as well as this, we could do a lot more through different ways of public engagement for the future. And thank you very much for giving us the opportunity to do it.
Thank you very much, Susie. So we've got the paper in front of us. We don't need to go through the document in detail. I'm going to assume that people have had a chance to read it, and certainly we had a discussion within our private governing body a month ago before it went to the engagement. There have been some minor changes which have been documented in there as a result of that engagement, which is really helpful. And we have been asked to make some recommendations. So Susie, the plan for this, or the hope for this, is that it's approved by all of the NHS organisation boards.
Absolutely.
So it becomes the framework, the system framework under which they can operate and their ethical governance can operate, and gives that system consistency. Is that right?
That's right.
Okay.
Yes, absolutely.
So before we get to the recommendations, any questions or comments for Susie before we go through those? Judy.
Well, firstly, thank you very much, Susie, and to everybody on the group that has taken on this very challenging piece of work. And actually, it's really good to be, although I've done nothing other than say support all the way through, to be part of something that is such leading edge and taking on really taboo issues and difficult, hard issues. So thank you. My only question is, do you think that anybody in the system that is going to be signing up is unhappy about it, that we should know about? I know we'll take our own decision, but is there any reluctance, indication that anybody might be objecting to it?
Good question. Not that I know of. I mean, nothing that came up during our deliberations as a committee or since. No, nothing that would lead me to think that one of the boards would demur from adopting it. No.
Thank you.
And Susie, because I know our two of our local authorities are represented here by their directors of public health, but they obviously have their own statutory guidance that they have to work through. But can you just confirm to us that we ensure?
Yes, that we considered, yes, and the ethical framework makes reference to this. So there is some ethical guidance for local authorities, and we believe that this framework is consistent with that guidance. We did test that. We had a representation from local authority on the reference group, and Virginia Director of Public Health was also a member of the reference group.
And Susie, we had Craig McArdle, didn't we, representing the 3 directors of adult social services as well, because it was during the discussions we realised that the social care and the public health aspects were actually quite complementary to the other considerations, which worked really well.
Yeah, yeah.
And so I think that's a good example of an alignment that we've managed to achieve in a very complex issue between local authority and NHS within Devon. So again, another real positive that's come from that.
Yes, absolutely.
Simon.
Thank you, Paul. Thank you, Susie, for this paper. I think it's a really helpful guide. I can see the sort of line of sight for individuals clinicians in acute trusts and having their local ethics committees and then reporting, or at least potentially escalating to a Devon Ethical Reference Group and the Southwest Regional and Social Ethics Reference Group. How do we use this in practice, both in primary care and secondary care? And is there a kind of a template or a kind of document that we would be expected to record what we did in the event of having to, hopefully never have to, but having to make some of these decisions? Is there a way that we would be expected to record that so that we've got that to provide support for ourselves if there was questions after the event?
Yes, so the allocation withdrawal guidance does cover this aspect about recording in writing decisions taken and reasons for decisions, including whether a decision was taken in the context of inadequate resource. So I think that is important you do that. I would stress that I don't think this guidance is in any way in disagreement with your normal professional guidance provided by the GMC. So I think it's in keeping with that, but it's just, so in terms of principles, but it's just more developed and more applied to this specific situation of having inadequate resource. Now, the guidance also says this is about critical care ventilators, but the same applies, to other situations. So I think you can apply it more broadly than simply critical care for COVID.
Yeah, and I think, Susie, it's rather than giving a template that can be filled in, it's a framework that will help you work through the right way of coming to a decision and the right questions to ask, the right things to document in that process, the right people to engage in that decision making, and also give you some support when you make that decision, that you are following something that has been approved by the organisations in your area and has been out to public engagement. So it gives you a degree of confidence that if you follow the framework, that you are doing everything you can to make the right decision for those individuals when faced with it.
Absolutely. And one of the things that we've been very careful to set out is that these are not decisions that should be taken by clinicians alone. They're far too important and far too difficult. So we do say how a wider group should be involved, including people who don't have direct clinical responsibility for the patient. Other ethical guidance in this field has adopted the same approach. There was some guidance developed a few years ago in New York, which had a very similar approach of emphasising the need to have some people who aren't directly responsible for a patient. So you iterated amongst several clinicians. No one bears the burden alone.
Thanks, Susie. That's really helpful. And actually, we got practicing that in primary care when we were deciding whether we should bring someone potentially high risk during the height of the pandemic into a setting where they should be reviewed. And we were very much encouraged clinicians to make that decision collaboratively rather than on their own, feeling isolated in making that decision. So this then extends that behaviour to some of those more challenging situations we may face. Nick Kennedy.
Hi, thank you, Susie. This is a great document and will be very helpful, I'm sure. to clinicians involved at the sharp end. The only question I've got is, which isn't entirely clear to me from the document, is what's the procedure for the decision making in an emergency or out of hours? Because in my experience, sometimes some of these things which require decisions, if they happen at 3 o'clock in the morning on a bank holiday weekend, it's not the backup isn't there to do that. So what is in place to ensure that should we need to be making these sort of decisions inconvenient times or difficult times, that there is some support there?
We say at the end of the document, where we're talking about escalation, that in the event of the system beginning to feel more overwhelmed than it ever has so far, and than I think it ever will be, but in that situation, that the ethical support would need to be there 24/7. So we have thought about this. So that would be at hospital level, but it would also necessarily be at the reference group level as well.
Okay, so you'd put that in place if you thought it was required. Absolutely, yeah. Yes. Okay, thank you. The decision taken at 3 in the morning by someone on their own, is intolerable, I think, in these circumstances. Yeah, I agree.
And one of the things that was picked up, and certainly in some of the engagement, was about decision fatigue that clinicians may well face, because particularly in a critical care situation where they are facing a large number of these decisions, and that was one of the things that drove the need for that extra support to support the clinicians in that. Graham.
Thank you, Chair. Susie, as others have said, this is a super piece of work that's been prepared in a really exemplary way. Any policy is only as good as how it's implemented. So my question is, how will this now be rolled out to the sharp end, to those clinicians on the front line, assuming the document's approved by all the various trusts and bodies? How do we get the information to where it needs to be for all those people making individual decisions?
Yeah, so what will happen now is that each individual trust will, as this board is doing, consider it and hopefully approve it, and then it comes into existence and it's a standing common document policy. We had a discussion as to whether the Devon Ethical Reference Group should have some responsibility for monitoring how this is used. And we rather felt that because we are just an advisory group, that it's really for the individual organisations to monitor, perhaps through their ethics committees, how this is adopted and played out in practice. If we were to be asked to do it, I think that would be a different matter. But at the moment, I don't think we are pushing for a monitoring role.
Penny.
I was just going to thank you, Susie, and thank you for presenting this today. It's excellent to have you here talking in the detail about it, because I covered it briefly in our private meeting, but obviously have not been in some of the detail. But some of the really important things is that every hospital and every provider has a responsibility for its own ethical committee, and therefore for the dissemination and ensuring that. And I think it's important that we don't walk across that responsibility that they have in their individual organisations. But the absolute gem of this framework is the consistency across Devon, which in the sort of circumstances we're talking about here is absolutely critical. And this has been absolutely super, the engagement with this. So again, like anybody else, thank you, Susie, for leading this.
Can I just put a challenge to us, and it's James, I'll bring you in just a second, as a CCG. So obviously we're making a decision on how to adopt it. There will be something about what does that mean for us as a commissioner. We don't have an ethical committee. We have, by agreement, we have the support of the ethical reference group should there be ethical considerations for some of the commissioning decisions we make, which will be hugely helpful. But we've also already mentioned primary care, and what does this mean within primary care? And so do we need to think about what is our responsibility in supporting primary care to view and to be shaped by this framework and supported to act within this framework. And I guess it's probably something it'd be interesting to hear some of our GPs and Joe and Judy their thoughts on whether that's a role that we would take on in support of this document, because of course we don't have 130 odd ethical committees in each one of our primary care practices, so they would need some support in that. James, while people ponder that one.
Yes, thank you, Paul. And thank you, Susie, for this document. It's really interesting. I've never come across an ethical framework before, so this was my first, and thank you for it. I just wanted to come back to Nick Kennedy's point about out-of-hours decisions, and I wonder if in some way this might be mitigated by, in the report, it does suggest that, and I know this isn't always possible in a hectic clinical setting, but it suggests trying to reach decisions with people well before they reach those sort of final stages. So hopefully, if the ethical framework is followed and is able to be followed in that setting, then people's decisions will be established fairly early.
Yeah, we do very carefully say that. You're absolutely right, and I think that's good professional practice. But there will always be situations, of course, when the unexpected happens, and therefore I think this point about 24/7 cover is a really important one.
Thanks, Nick. I think you're on mute, Nick. Oh, no,
sorry. Thank you, Chair. I was just wondering whether we should consider as a CCG how or if we attach the ethical guidance to the contract for our major, at least, non-NHS contracts. Is there some way that we could widen the coverage of this beyond NHS organisations? So I'm thinking about the third sector particularly.
I think that's a fair challenge. That consistency, not just amongst our big providers, but throughout the whole of the care provision within Devon. We'll see whether some of our executives might know the feasibility of that, or whether that's something that you can take away and consider. It may not be that we can answer it here and now. Judy, and then Joe, you've got a point, but you might want to come back to Nick on that one as well.
So taking your point, Paul, I think you're right. We should look at what support we give to primary care. The philosophy we've taken in our role with primary care is to be supportive, but recognise they're independent businesses. But I recall this being a very popular topic in the workshop. The weekly workshops you were doing with primary care during COVID, and it picked up on James' point about, or the point he referred to, about conversations in advance, wherever appropriate, which means that actually care homes and primary care have a very big role in this. And so it's really important that we do some stuff on this. And may I say thank you to whoever keeps lowering my hand for me, because I was forgetting earlier. But I think we should take it. Joe will know more about what we've done within primary care on that already.
Yeah, thank you.
And as if by invitation, Joe.
Thank you. Yeah, so I'll try and pick up the primary care issue and maybe some of our other contracts as well. So I think Judy's absolutely right from a primary care perspective, really conscious of practices being their own businesses. But actually, I think what particularly the last 4 months has taught us, and actually that weekly connection with primary care, is as soon as something like this comes along that's different, actually there is a definite want there to work collaboratively as a system and to want some support. And I think that's been really clear. And I think, actually we've had some really good positive feedback about that. And there have been times where I think, and particularly you, Paul, and going back and using the sort of clinical reference group, etc., where that's been really important as part of the COVID response. So I can absolutely see a need for this in primary care. So I'm wondering, Paul, whether there's probably, it will take it outside of here, but I think it's something that we should discuss with the LMC. So I think that would be my first port of call for that, and then happy to take that back through primary care committee in terms of kind of, you know, sort of an update on where we've got to on that. And I think then probably similarly for some of our out of hospital providers as well, and I think again what we've learned, and we kind of said it earlier on, didn't we, the importance of out of hospital providers and also external to NHS providers during this last 4 months has never been as obvious as it is at the moment. And there are some, you know, there have been some difficult decisions, and there may be some more difficult decisions to come. I was just wondering what I suppose the capacity of the group was, I guess, to deal with some of that. But I don't, just listening to Susie earlier on, I don't think this is going to be, you know, this isn't about the everyday, is it? This is about the sort of the exceptional, some of those really, really big, tricky decisions. So it wouldn't feel, I don't think, particularly onerous. And I think they're decisions that, or they're conversations that we could have with those non-NHS partners as part of those, particularly as part of those LCP conversations. And I think my sense would be they would be really welcomed as well.
I mean, I should say that my sense is, because of course the South West Regional Ethics Committee is also recently being set up, is that one of the things that COVID has provoked is a greater interest in the ethics of health and social care. I mean, perhaps brought, you know, most clearly into focus through some of the failings of how we've looked after social care providers, really. But the South West Regional Ethics Committee, for instance, is going to look at ethical aspects of public health management. It's going to look at ethical aspects of referral from primary care to secondary care. What should the standards of communication be, for instance, in those settings? So I think there's a number of areas now which are really going to benefit from looking from an ethical lens at practice, and I think that will help improve things. So I think this question that you've raised about, well, do we need more for primary care is right, and is a good one to be discussing.
Okay, thanks. And Joe, I think it's right. It's an LMC discussion to get them involved, and then we can work with Judy through the primary care committee about a process by which we can support primary care to look at this framework and look at adopting the framework. I'm going to bring Nick Kennedy and then Simon Kerr, and then I'm aware of time, and then we will go through the recommendations. Nick.
Thank you. My question is, Paul, you asked about the CCG not having an ethics committee, and would it benefit from, you know, having access to the Devon Ethics framework and committee for some of our decisions? And so I just posed the question: we may have in the next year or two have to make some pretty unpalatable decisions about allocations of treatment and not doing things and stopping doing various things which up until now have always been done. So firstly, is the ethical framework as it stands fit for that sort of purpose? And secondly, is that the sort of thing, should we be consulting with that before making those sort of decisions?
Okay. So I would say, if you want me to respond to that, Paul, I would say no, not in and of itself, but there is a piece of work that the Regional Ethics Committee is doing, which does address much more pointedly the issue about prioritisation. It doesn't give you any easy answers, but it does lay out the sort of the difficult territory that needs to be considered. So when that's completed, I'll send that in through Paul, if I may, and perhaps you could look at that and then see whether you would want us to do any more work. That's probably the best approach.
Yeah. Okay. We can. Yeah.
Thank you. Can I just pose the question on that, Paul? Of should we, as a CCG governing body, be thinking about if we have to consider those decisions, should the ethics of it and getting an ethical opinion be one of the first things that we do, or do we not need to do that? We don't need to answer that now, but I posed the question.
I think that's a good question. I think the importance is that we ask the question. Where it comes in that process, I think we'll probably need a bit more reflection to determine. But yeah, I think it's got to be a question that that is part of our process. In the same way that we have a QEIA approach to our decision making, there needs to be an ethical emphasis on that. Yeah, that's a good point. Simon.
Just to say, Paul, I think everything that's been said is helpful with regard to primary care. We very nearly fell into some big gaps at the beginning of the coronavirus outbreak with not having this type of information, and there was all sorts of talk about all sorts of different scoring systems we were going to use, and a lot of us, some of us, felt very, very uncomfortable about anything to do with the scoring system. But we didn't have anything else, and what we did have was 3 or 4 different versions of the truth from different parts of the country that were really not very helpful. I think we need to get this to the LMC, we need to get this to the local care partnerships, we need to be working each of our partnerships together with our fellow clinicians in secondary care and primary care, and we need to be able to give our colleagues in primary care really clear guidance that this is as to how we need to behave if we are faced with a second wave, and this is really reassuring. It's what we want, what we would say we would do anyway, but it's actually very much more reassuring as a framework to work to than what we were being given by lots of different people with regards to scoring systems, which felt very, very uncomfortable. So yes, we need to help primary care to be able to use this in practice as soon as we can.
Brilliant. Oh, well, then let's, if we go through the planned approach that we've got, which Joe outlined, with an initial discussion with the LMC and then an agreed route through within primary care committee where the LMC is a member as well. I think that, and then we'll keep those of you GPs who aren't part of the primary care committee, we'll keep you in the loop as to how we're getting on with that, and then what the plan is to disseminate and support that dissemination. But yeah, I think that just reinforces that. Okay. Susie, I don't want to preempt the whether this is approved or not, but I'm just going by the general tone of the conversation that we might be all right. So if we go through the recommendations, we've noted for C, D and E the documents and the reports that are contained within our board packs. So let's go for A and B and let's take them together. Can I ask voting members, do we approve the Devon Ethical Framework and the Devon Guidance on Allocation and Withdrawal of Treatment, both in Appendix A and B of our packs? I'm going to go by exception, so if you raise your hand, then it means that you do not feel able to approve those. And no hands are raised, and so I'm going to take that as an approval. Thank you very much, Susie. I hope it's as smooth with the other boards.
Before we finish, sorry, Paul, can I just, before we finish, acknowledge Adam Carrick's work in this. He is the secretary to the reference group. He's been absolutely superb. I'm only here today because he can't be, but he really has been brilliant. So I want to thank him through you.
Great, thank you very much. Thank you, Susie, for this. You are welcome to stay, but I'm aware you have lots of demands on your time, but feel free to stay or go whenever you are ready. But thank you for giving us your time and going through this. It's been really helpful. Okay, so we will go back to item 5, which is the chair's report. I'm going to take that as read. The only thing I want to highlight on there is, just for it to be recorded, I just want to say thank you to Simon. Because he has gone above and beyond in the way that he has led us as an organisation through COVID. I've been closer to the executive team than I would usually be during coronavirus, and I've seen him at work, and I've seen the way he's put in the effort to work very closely and to support his team, and also to support the wider chief execs of the system. He is having a much needed 2 weeks off, and so I hope that he gets the rest that he needs. But actually, I think he has done a stellar job as our accountable officer over these months with the challenges that we faced. So unless I have any other questions, I will take that as the chair's report. That's fine, thank you. So John, in Simon's absence, can I ask you to take us through the Accountable Officers report, please?
Yeah, thanks, Chair. Afternoon, everybody. So just briefly, the report is in the pack, so I'll assume people have had a chance to read through it, but I'll just amplify a couple of points to sort of make sure the gist of what we've put has come across. We've also been joined by our colleague John Finn, who's leading the work on restoration and transformation. So I'll run through the entire report, but then I'll pass over to John specifically just to pick up a little bit more detail on what's going on in restoration and transformation. So the things covered in AO report to update governing body. Latest on our COVID-19 response, where we are in that, and as I say, that will lead into a little bit more on restoration and transformation. An update on 111 first, or Think 111, depending on which language you prefer, and then just the latest on our thinking around the procurement process and the service contract that we're looking to let for integrated care in the west of the county, just to update on that. So as far as COVID-19 response goes, sort of in keeping with where we are and the relatively low incidence of the disease now, we are stepping down a number of our incident management response as we start to get more back into business as usual, and those changes are set out in the report. The important thing there is, of course, as the rest of the country is doing at the moment, we keep a weather eye on the environment that we're working in, and if necessary and at the right point, we can stand up a number of those processes again. But our sort of general direction of travel is to move away from emergency response and more into business as usual. Nightingale Exeter, people will know Nightingale Exeter has been completed and has been commissioned and handed over to the RD&E as the host organisation. It will be used in the short term as a diagnostic centre to provide us some more needed capacity around diagnostics, but it remains as a key part of our surge capacity should we need to commission it for that purpose as the next few months progress. We're also looking very closely working with our team at what our arrangements are for returning. So at the moment, and people will know, we've been working exclusively from home, following the guidance of if you can work from home, do work from home. That's been relaxed a little bit, as we know, by government, but we're working very carefully with staff about what some kind of phased return to office-based working for some of the team would look like. We're expecting to see some of that in August, but probably with more coming in September. But important before we do that all the necessary safety arrangements are in place. Restoration transformation, I'll leave, not steal any of John's thunder to come in at the end. 111 First is an initiative really looking at how we ensure we've got optimal flows through urgent care in particular. So how we work to provide a safe and efficient urgent care, emergency care services, whilst we still have the presence of COVID-19 in the community is what that's about, and ensuring that we're directing people as much as possible to the most appropriate setting for their care on the first time. It'll be run as a project. Philippa Slinger, the lead chief exec for the system, is leading that project on behalf of the system, and we'll work very closely with Philippa on that. And the last thing to mention, the Integrated Care Partnership. So as part of what I'm sure John will talk about as phase 3 of COVID response, that's about making sure that we've got a smooth transition to help us to plan for the rest of this year, including the winter period. As part of the thinking around that, we've been thinking about the provision of integrated care. We did take a decision earlier in the year off the back of the impact of COVID that we would slow down the procurement, and we probably wouldn't look for the starting of that contract until probably April 2021 at the earliest. We are reconsidering that decision and working with our preferred provider about what opportunities we've got to potentially accelerate the timetable for the award of the contract and the implementation of integrated care in the west of the county. So just a bit of a heads up on that we are working through that process at the moment. So I'll pause for any questions on any other aspect of the report, anything other than restoration and transformation, which we'll leave until after John's had an opportunity to speak, if that's okay.
Okay, so anything for John Dowell? No, then John Finn, over to you if you want to take us through the restoration transformation paper.
Okay, so John Finn, Associate Director of Commission at the CCG, working to Penny. As this is an appendix to your report, John, do you want to give me 5 minutes just to walk through it before taking questions, or would you like me just to take questions direct?
I think probably good, John, if you just pull out a few of the highlights. Yeah,
will do. So in terms of the purpose of the paper, it's got 3 aims actually: to demonstrate the work undertaken in phase 2 of the pandemic, to detail the CCG's service restoration process, and finally the plan underway in relation to phase 3. I think it's important just to be clear that this paper is a point in time. The work going forward is working at great pace. So in terms of at the end of April, we had the Simon Stevens letter to all organisations, sort of thanking teams for the remarkable response to the COVID response. It also set out some actions required as part of the second phase. I have to say, in terms of the letter came at a perfect time in terms of to galvanise both the approach of the CCG and the CCG's leadership approach across the STP. It also asked for organisations to consider the learning from the response to the crisis and how all innovations that we had seen would continue. It laid out 43 objectives to be completed by the 12th of June. Now, again, I have no intentions of going through those actually, but they were focused on urgent routine care, women and children services, mental health, learning, etc. And I'm very pleased to inform the governing body that we did achieve the delivery of all those actions within that time frame. In order to deliver that, actually, we'd already set up a team to coordinate the COVID restoration response. Feedback from system partners was that the governance around this should be effective but light, and we very effectively used groups that were already operating around cancer, elective, primary care, mental health, etc., rather than setting up some new ones, which proved to be very, very effective actually, and kept the governance as requested. So all during the initial phase of response, I see patients still had access to GP services, pharmacy, optometry, etc. So, but I just like to highlight a couple of, I think, success stories, particularly in terms of the phase 2 process. Our approach to the utilisation of the independent sector was different to the rest of the country. Rather than focusing on COVID patients, particularly respiratory patients, we used activity to ensure that any patient who required urgent elective, urgent cancer or urgent diagnosis could access that care. And we are certainly recognised regionally as being one of the most productive systems in the country in terms of use of that. And I need to highlight that this capacity in the independent sector is still critical to our restoration in phase 3. So I'm just going to highlight some of the actions that we undertook to meet the expectations of that letter, such as strengthen the capacity of out of our service, including 111. Our discharge processes have excelled during this period. Actually, there's been a significant amount of time, effort, and leadership in terms of working with both our acute trusts and our social care partners. There were many transformative, positive changes in the way healthcare was delivered. Actually, it was really important to embrace those changes going forward. And there's some good examples would be in terms of the increase in non-face-to-face appointments in primary care, which I heard prior to the formal meeting, mental health services and secondary care appointments. These were all part of our strategy pre-COVID actually, and just we really did accelerate these beyond expectation. So some of the organisations, particularly Devon Partnership Trust, are leading the country in terms of using some of these digital processes. We also, critically important, we set up a system restoration group across the STP, co-chaired by Alison Wilkinson and myself. I think Nick Kennedy is one of our governing body members, actually joins that, and that was very much to support restoration of services, but also embed the learning from COVID and any barriers that could be identified, actually making sure that we'd wade through those actually. Any service change that had taken place with other providers was shared at that actually. So with a really good whole system approach actually to phase 2 and looking into phase 3. I've just detailed the membership of that group. So with very senior individuals across all aspects of health and social care in the county. So what was the impact? So it's I think our Devon referral rate is about 70% of normal being last year. 2-week wait, thankfully, is now back where we would have classed as normal actually. But there was a very low starting point from mid-April, and I said a lot of the impacts of phase 3 actually will need to respond to the result of those low referral rates at that time. Our 52-week waits unfortunately have quadrupled from March onwards. Actually, may have been the most validated position. I think if it turned to point 30, I think I think certainly the governing body and some of the other conversations I've heard pre to this, the work was a really good, robust process and work stream looking into understanding waiting lists across the county in terms of the categories of clinical risk, that being a priority over waiting time. All the providers in the county actually operate within the categorisation issued by the Royal College of Surgeons, from I think 1A being the been emergency, 1B urgent, leading down to priority level 4, which in theory could have been delayed for up to 3 months. But as we've been in COVID for more than 3 months, actually, a really important piece of work we're undertaking now is Devon-wide, where how are we understanding actually the groups of patients who now sit in these priority groups. Urgent care activity has broadly recovered to pre-COVID levels. So what are we doing about that? The Royal College of Emergency Medicine has necessitated a review of our services in terms of aiming to keep ED attendances 25% below pre-COVID levels, and that's led to the work which is Joe's leading on in terms of 111 first, etc. So I think the examples, actually, I don't really want to go through the time to go through the examples of learning, but we can't underestimate actually just how much there has been. I think primary care has actually led the way in terms of using digital and non-face-to-face approaches to its delivery. As mental health, although no services are actually stood down, actually the means by which they transform the services to continue to deliver high quality mental health services has been fantastic, with some excellent examples in terms of there. Now we will still be focusing on out of area repatriation, children, families and young persons, and physical health checks, but there are some really good examples actually in terms of how mental health services have responded to changing need through COVID. We also set up a CCG restoration process actually, as it was previously reported to the governing body via Simon's reports actually, that we'd introduced a service change process right at the start of the pandemic, which is primarily for standing down services. We reversed that in terms of using quality and equality impact assessments actually to review organisations returning their services. So which again continues on that. I report to the executive every Friday on those. So finally, to move into phase 3 planning, we haven't had the phase 3 letter from the department that we would have been hoping for actually, because I said I do reflect back in terms of how useful the first letter from Simon Stevens was actually, but it is due to be imminent. But it's, and again, important to reflect that all the pre-existing financial performance issues that the Devon system had prior to COVID still are maintained and are material to our system planning. So all the issues around value for money, benchmarking of cost, benchmarking of performance recovery, and reduced cost base need to be taken to be taken into account as part of phase 3. In the absence of the phase 3 letter, actually, we've had some guidance from the regional team around a set of planning principles. Primarily, they focus around the requirement for a single operational and winter plan, which has been jointly developed by all partners. So I said the remaining parts of the paper actually detail how we will do that, but I can confirm and assure the governing body actually that our processes around that are very well advanced. I would say based on previous years, we're probably about a month ahead of where we would have been in previous years in terms of having a first go at an operational plan which takes into account whether there's a second surge of COVID, change in R rates across the system, the change in opportunities around whether or not some of the capital investments we put in will be received or not. So a very, very strong base for taking our system into phase 3. So I'll pause to that. I know that's a very quick run through, quite a long document, but happy to take any questions on either the document or our planning around restoration.
Thank you, John. Before we take questions, can I just thank you? It's a huge piece of work. Everything got stood down really quickly, and then the pressure was on us very much from NHS England to stand things up as quickly as possible. And you've taken an approach that's kind of optimised the speed which we can do it, but actually done it in a safe way. So thank you for you and your team for doing that. I think it's been an excellent piece of work, and it continues to be a really good piece of work. Simon.
Yeah, thanks, John. Thanks very much for that. I think if we get the strategy right, and we get the operational change right, and we get secondary care as they are doing, delivering outpatient care digitally, and we get them even maybe to do some first outpatients digitally, and we therefore enable them to shorten the time between referral to perhaps first diagnostics by doing the first consultation digitally. Do we have any insight into what the financial impact of that might be for us, and or the outcomes for patients might be for us? I just wonder whether phase 3 is going to be looking at that.
So in terms of the outcome for patients, I'm working with the quality team to understand where, although the majority of those non-face-to-face contacts are positive, actually, we obviously need to make certain that we don't disenfranchise patients in public who can't access care in that way. So that was a core theme right from the beginning, actually. So we're working through that patient. In terms of formal consultation, that's been very hard to do, but certainly the ad hoc feedback we've had actually we'll be using to inform the future planning. But on the whole, it's been very positive, actually. But I said certainly during the period of people having to isolate, actually we really did need to take into account how patients would be able to access services if they couldn't do that in the digital footprint. And the second one, in terms of the planning, so can you just repeat the first question? Actually, I don't want to get that wrong.
I appreciate that it's not been that easy sometimes to get hold of people digitally, but when you can sometimes short circuit the number of weeks it might take for them to have the X-ray, for example. So we in primary care, we're all the time we are talking to patients on the phone that we would have seen, but we're talking to them and then arranging the X-ray without seeing them, for example. So we could have our first outpatient consultants doing that. But what are the implications for us in terms of cost potentially? Are we going to suddenly have a huge number of greater cost for diagnostics and a greater waiting list for that? And are we going to get poorer outcomes for patients because patients aren't actually being seen face to face?
Yeah, so I think in terms of the cost base, so in my last part of my paper, I described the need to take that into account now. So certainly in the first phases, actually, there wasn't a lot of discussion about cost and future costs. But I met with I joined the director of finance colleagues last week actually, and where we did talk through the need now to understand the revised cost base of some of these services. So the ability to undertake 2.5, 3 times the amount of outpatient activity in a session compared to previously, because it's not face to face. Actually, we need to quantify what that means. And I said it's quite a difficult conversation because we're still in the throes of the pandemic. But we did agree that Kevin Will and myself actually would take that work forward, particularly around the outpatient work, to understand how that has changed, and really importantly, in terms of any contracts or plans for next year, be able to reflect those new cost bases in those. In terms of the outcomes for patients, actually, it'll be you'll be aware. I think we did discuss it in the Easter meeting last week. Actually, now our access to diagnostics particularly has been impacted on, and I said no, we have been able to provide urgent diagnostics throughout the period basically, but the backlog in particular CT and MRI is significant. We're probably about 25% under provision at the moment in MRI, and somewhere between 40 and 30 in CT. So it'd be wrong not to say there will be an impact on that basically, but our prime focus at this moment in time is getting that capacity up. We will need to work with our quality teams in terms of the negative consequences of that lack of capacity. So it is a real risk.
Yeah. Thanks, Judy.
Thank you very much, John, and that was a very good report. I want to make a slightly broader point. You introduced your paper, and this is to all the executive really, and to Paul. You introduced your paper as we did this because NHS England sent us a letter, and Paul reflected this NHS England instruction. But in fact, you'd set up a restoration, you may have used a different word, piece of work beforehand. And I think it's really important in terms of the massive amount of work and energy that you as an executive do in advance of instructions coming down from the centre, because you have spotted that this is something we should do as commissioners for the population of Devon. And it's really important in our mindset and our language. Of course, we follow what the policy is from NHS England, but we don't only do it because NHS England sent us a letter. And I think that for our residents, it's important to know that we were thinking about what Devon needed. We were thinking about how our providers, I recall the conversations, and then somebody said, oh, by the way, that's been helped, as you said later in your piece, John, by having this letter from NHS England. It's just a mindset thing, because I think this organisation has the way in which not just the CCG, but the CCG and the providers together were both handling the situations that we were dealing with, but also then getting ready for the next thing. We were doing that on our own. We weren't just waiting for instructions from above. So all credit to you all. I know it's still a lot to do, but
I think that's a fair showing that we should recognise our own initiation. And our own initiative in these processes. Thank you, Judy. Thank you, John. That was really helpful update, and I'm sure we will have more of those coming to governing body as we progress through this process. Thank you very much.
Okay, thank you for your time.
John, item 8.1, the month 3 finance report.
Thanks, Chair. I'll try and be brief again. The paper included in the pack is the financial positions to the end of June, and just a reminder that we're currently working within the temporary emergency financial framework put in place by NHS England and Improvement to support the NHS working through the response to the pandemic, which in essence means that all of our costs will be covered for the period of that emergency framework. In the paper, it refers to that framework being in place until the end of July. It has formally been extended until the end of August now, so we know that we'll be operating with the emergency framework at least until the end of August. the easiest place, I think, to see the summary is on the table on the top of page 99 in section 3. It shows the expenditure that we've recorded, both directly related to COVID and on our underlying expenditure on other services that are not directly related to COVID, although obviously everything is impacted to a greater or lesser extent. What that shows is we've recorded to the end of month 3, 18.5 million of directly related to COVID expenditure, of which earlier in the report it refers to date we've had 11.6 reimbursed. The gap in those two numbers is not that we won't have that reimbursed, it's just that we're still working through the assurance processes with NHS England and improvement on that. There's a forecast included in that table. Just to repeat, that forecast is not a full year forecast, it's just to the end of the emergency period, which in this report is to the end of July. Section 4 of the report, page 105, just gives a little bit more detail on what the COVID-related expenditure has actually been. So happy to pick up any questions. If that's significant in the numbers, there is some expenditure on the setup of Nightingale Exeter, and also expenditure on the Faster Hospital Discharge Programme is a very significant part of that, and that has been a key plank of our system response to COVID. Then finally, from my perspective, section 6 talks about risk. Clearly the biggest risk that we have at the moment is uncertainty, really, and that's uncertainty about what happens in terms of our allocation for the population and our expenditure profile beyond the emergency period. We're working to understand that to the best of our ability in terms of what the forecast expenditure looks like, such that once we have confirmation about what the allocation going forward is, we will be able to make that comparison. The areas where we are still concerned about the level of expenditure being higher than was in our previous operational planning assumptions is around primary care prescribing. That will be a common theme. So we'll do some more work on understanding that, but we are also in dialogue with NHS England Improvement about what the reality of some of that is and the impact that the ongoing effect of COVID-19 will have on expenditure in that area. That's all I wanted to bring to attention, but very happy to pick up questions on the detail in the report, Paul. Thank you.
Thanks. So while people think about questions, can I just, it's an example of how one typo can give a very different meaning. So underneath that table on paragraph 4, the third paragraph after the table, it says we will continue to work without local authorities. It's just one I've spotted, but it does show that you one typo changes the whole meaning.
Yes, thank you for spotting it. I hadn't. You should say with our local authorities, or with local authorities, but definitely not without.
Definitely not without. I figured as much. And certainly with our local authorities embedded in our governing body here, let's be clear that it is a joint effort. A lot of the stuff that we've managed to achieve, and particularly around care homes. Joe, I'd like to, I'd just like to ask you about primary care prescribing. What do we see as the opportunity in the current climate with COVID around and with the other pressures in primary care for trying to implement some of those programs that we understandably put on hold when the pandemic was at its greatest?
Thank you, Paul, and that's good timing. You didn't know this, but we had a meeting yesterday to discuss this very thing, so I'm glad we did. So we met yesterday with really the aim was to discuss how we restart the QUIP programme for medicines. We know that we think within the current financial kind of overarching sort of framework that's in place at the moment, we think we've got until the end of August to make sure that we've got a really good, robust plan in place, which needs to start from the 1st of September. So for the remainder part of the year, we've got a £5.25 million challenge remaining for our QIP that won't be picked up, obviously, through this current financial framework. As I say, the conversation we had yesterday was very much about what's going to be our strategy towards that, and what's the engagement that's needed with primary care in this time. I have to say, what came out really clearly from that conversation is that this is going to be quite a particularly challenging time to do this. So before, we've relied quite heavily, so we do sort of couple main things, if you like, through our meds QIP programme. And some of that, or all of it indeed, obviously relies quite heavily on GPs needing to do something, whether that's supported by our own pharmacists and advised by our own pharmacists. But at the end of the day, it's the GP's name that's on the bottom of the script there. And the conversation we had yesterday is we've relied really heavily on switches. So this is from one drug that does the same thing as another one, but it's cheaper because, for example, it's a generic drug. And actually, that's going to be really difficult at this moment in time. So general practice is feeling under increased pressure at the moment. So it's needing to deal with being asked to bring its services back up to normal business as usual, but at the same time needing to cope with COVID, which we know brings its own challenges in terms of social distancing, but also the increased impact which the flu campaign is going to have this year for them as well. So we know there's a significant amount of stress and real concern in primary care at the moment, and actually relying on general practice to do some of those changes which won't necessarily impact on quality, but will impact from a financial perspective. Some of that's going to be really hard to do during this period. And even indeed some of the things that we want to do, which will absolutely improve quality, will be much more preventative and really support us upstream. Actually, it's just going to be tough because of capacity at the moment. So the conversation we were having yesterday is how do we support general practice to do that during this time? And we're meeting again in 3 weeks, Paul, and we will have a plan then. So we will know exactly what we're aiming for, how we're going to do it, and then what some of the gaps are and what some of the support is needed for that plan.
Okay, thanks, Jo. And I think it acknowledges just how tough it will be to do that within primary care at the moment. We've got to be realistic about that, but still push every door that we can to try and maximise the saving opportunity. Glynis.
Yeah, couple of questions. First of all, I noticed that corporate running costs seem to have increased, and I would have thought they would have gone down because people were working from home. So that was a question. The other question really links back to what John was saying about more work being done digitally, particularly outpatient appointments. And I remember last year when we were discussing transformation and QIP savings, a lot of that was based on digital outpatient appointments. So presumably there's going to be a big saving there across the system that could be used.
Yep. So I'm going to come back on both of those.
Yeah.
So on the running costs point first, this is where we tried to cover it in the narrative of the report, but it is one that's slightly confusing. So just to be absolutely clear, our rate of expenditure on running costs has not increased, and in fact we are seeing the reduction that intuitively you would feel you would expect to see, not least of all because we've had absolutely zero traveling and that sort of thing, so our operating costs are going down by dint of that. The variance that you're seeing there is the variance between what we're spending and a plan that was set to be monitored against, which is artificially low. So this is one example where, as long as we can demonstrate that our operating costs aren't going up, and they definitely aren't, that will be reimbursed as just a difference between the way the plan was set and where our reasonable acceptable level of expenditure is. To your second point, I think that's slightly different, and the example that you gave, the opportunity of where certainly operating costs will, I think, have gone down in that instance. That reduction in cost will obviously be felt in our provider sector. There are a number of other things, increased requirement for PPE, more time between appointments, that sort of thing, which is putting an upwards pressure on costs. And what we need to do in conjunction with our providers is to work out where that's all landing. Where that will take us to is we expect that as we exit the emergency financial framework that we're currently under, there will be an amount of money allocated to systems to recognise that there will be an ongoing increased cost in aggregate in providing services, and some of that may well recognise some of the pressure around prescribing, for instance. So we will need to work through what's a reasonable allocation of that picks up the net of those. Some things, the cost of provision will have gone down, but some things will undoubtedly be pushing up as well.
Thank you.
Thanks very much, John. Simon.
Yeah, thanks, Paul. I just wanted to come back on the primary care prescribing issue, if I may. It looks as though we have £4.5 million lower budget than we would have had even if we were standing still. So that's a real challenge for us to even to start with. So category M costs £2.5 million more than they were thought to be, and the budget was set £2 million less than the outturn for last year. I think that that poses a real challenge. I know that I come from a relatively low prescribing area in East Devon, but we are starting to look at opportunities we're being presented with and thinking actually those are really contentious with the public to change. So, for example, banning all antihistamines to all patients and asking them to buy them themselves. And actually, some of the opportunities we're being presented with are actually to prescribe more medication to prevent patients from having gastric bleeding if they're on certain other drugs. So I think that the opportunity, having taken quite a lot out of prescribing over many years, is getting less and less in prescribing. And I just don't want primary care to be seen to be either not doing its job properly or to be put under so much pressure that they make prescribing changes that may potentially cause serious adverse effects.
Yeah.
I know Joe. I know Joe wants to come in. I just want to pick up Simon's point. So similar to my response about the running costs issue, to the extent to which it's a shortfall in the budget that it's being compared against, Simon, we would expect that element to get sorted out. So this is because the emergency framework is using a slightly artificial construct. As long as we can demonstrate that that's not about increased expenditure, that's just about a problem with the way the budget's set. That particular aspect, we do expect that would be sorted out, but that doesn't detract from many of the other things that you were saying, which I think probably Joe wants to come back in on.
Yeah, so I was going to say the same thing as John about the financial position. Having gone through it with Ben as well last year, there was an issue in terms of the amount that we had to accrue for, but I'm assured that we will get that back. So I feel confident with that. Category M will always be an issue for us, and it will be something that we do have to distinctly separate in some ways from our QUIP programme. So it's still a challenge. It will still increase our financial problem, but we need to be really clear about what we're delivering as a QUIP, and as you said, Simon, what primary care are doing in that space. So I suppose there's quite a lot in what you said actually. So I'll try and cover the points quickly, but I think so completely agree with you, Simon. You're in a kind of a low area of prescribing. Actually, we've got some areas very significantly in the west, but also some places in the south as well, where actually still quite a lot to go at. So I do think it's about how we differentiate our approach slightly. In response to actually this is going to be challenging now, we're having to make some really difficult decisions. I think you're absolutely right. We've picked all the low-hanging fruit have all gone. Let's be clear about that there's always bits you can do, isn't there? But there are still some things nationally, when you look at the benchmarking, NHS England would say actually this is low value, so we need to make sure that we tackle those things. And also I'd say about some of those difficult things, it really will now be much more about not just what primary care can do, but it will be about system partnership working, because actually a lot of this prescribing starts in secondary care. And they're some of the really difficult conversations we're going to have now about needing to have that joined up approach between the whole system. So I'd be really keen, and one of the things I'm really keen to do is actually get the meds budget not just to be seen, the meds quip not just to be seen as a CCG issue now, but actually it should be a locality LCP issue to tackle. And I think it should be one of the things we put on the agenda as one of those priority pieces.
Thanks, Jo. That's really helpful. I can take Graham, Nick, and David, and then I'm going to move us on, and we'll move to the quality and performance report. So Graham first.
Thank you, Paul. John, just a quick question for you. It's something that we touched on in Finance Committee, but today you just sort of flipped by it, and that's just the savings plan. In our original budget, we had a savings plan of 22.6 million. That's obviously been set aside during the COVID period, but do you want to just update the governing body on your current thinking now about how we tackle that during what's left in the remainder of the year?
Yeah, thanks, Graham. So it reflects really the discussion that we've had about primary care prescribing as one of the elements of significant elements of what would have been in the original plan, and it's the so first of all, it is absolutely our intention to stand up elements of the QIP plan again. The issue is about reassessing what's reasonable and deliverable within the new context and the remaining months of the year that we've got. That's a bit of work that we're going through, and we'll bring back through Finance Committee, and Jo's just described sort of kind of the first steps along the road for that, for prescribing in particular. But we will do that with each of the original elements of the plan to just reassess.
Thank you.
Nick. On mute.
I'm up to about 50 quid by now. I just wanted to congratulate John on the really outstanding performance in terms of creditor payments within the 30-day timescale. Normally, this is a figure that I don't think matters very much, but in the current environment, anyone running a small or medium-sized business is absolutely struggling for cash, and particularly in the first couple of months, when the business support funds were very slow to come through. The people I know running their own business typically took 2.5 months to actually get some money in their bank account. You know, this could have made the difference between going out of business and not. So it really shows the CCG standing up in terms of its place in the Devon economy.
Yep, thanks, Nick.
Great, I'll take that, John, I reckon. David.
Sorry, just to come back to prescribing, and I've asked this question before about whether we are quorate with our employed CCG pharmacists, and I really just wanted to ask the question, bearing in mind what we said about prescribing spend, are those pharmacists still actively working on reducing prescribing spend, or were they reallocated during the COVID crisis? The reason I ask is just because I haven't seen a pharmacist or had any contact with one in the practice since Christmas.
So the person who'd be able to answer that would be Jo, unless someone else feels able to, but Jo's had to go to another appointment. So is anyone else able to answer? Otherwise, we will have to take that outside of the committee and get back to you, David.
Okay, fine.
Okay. But it's one I don't know the answer to. No. Okay. Thank you, John. Sarah, for the quality and performance report, and I don't know whether Darren's had to go as well. So
I just can hang on for 5 minutes, Paul, if that's all right. I'll just put a message in the chat box, but if it's on the agenda now, I'll just send my apologies for a few minutes to the other meeting.
Okay. Well, do you want to go first, and then Sarah, so that you can get to the DDoC meeting?
Yeah, that's fine. Thanks, Chair. So again, I'll take the quality parts as read in the report. I suppose just a few things to bring to the governing body's attention. There is quite a significant amount of work to go on based on the performance element around this, so how we shift our quality view to get far more foresight. So to really understand the potential impact of quality based on the performance that we're going to go through shortly. Obviously, we spoke earlier about the 111 impact and the significant areas or concerns around 111 abandonment and the work that we're doing as a CCG to support the provider in that particular area. We've also been having conversations wider with the Quality Surveillance Group, with NHSE and the CQC around how we better understand potential harm and the risk stratification. Again, this links to our forward view working. Again, also earlier on today, the governing body heard the challenges around the significant incidents and the delays in investigation or outcomes and learning with our mental health partner. And again, significant input is going in there. And I think the only other area just to highlight are the areas of good practice within the care homes. You know, real good piece of joint working between ourselves and our local authority colleagues in terms of really improving the infection control and minimising outbreak and impacts of COVID within our care homes across Devon. Happy to take any questions.
Okay, thanks. Anything for Darren before he has to go? Okay, thanks very much, Darren.
Thank you.
Thank you. And so, Sarah, the performance element of the report.
Thank you, Paul. So this is a paper for months 1 and 2, April and May, and John Finn has, I think, very ably set the scene that this performance paper underpins the restoration and recovery work by putting the numbers down in terms of the progress or not made over that period. So to reaffirm that in that period we've made better than the national position compliance around diagnostics, particularly with the help of the Nightingale in A&E and in cancer waiting times, but in relation to 18 weeks clearly have fallen behind the national performance position. In looking forward, we've had some new guidance out which is starting to step back some of the reporting arrangements, and we have expected national guidance on performance nominally from the 1st of August for the last week and every day this week. And so just picking up Judy's point of earlier, we decided not to wait specifically for that guidance to come out. We've preempted it. I've been working with the chief operating officers in the trusts, and we've agreed an approach to performance locally, which is to look at health inequalities and to see how we could pick up on particular standards on a locality basis to make real impact and change going forward. We hope that that approach is going to be reflected in the national position when it's published. So I think, given that the theme of performance has come up throughout the day, I'm going to pause there and take any arising questions.
Thank you, Sarah. So I guess I've got a comment rather than a question, which is just that, you know, as we can see, for some areas where we've historically been well below the national average, we have deteriorated as one would expect, but not to the same degree as other areas of the country. And I think that's you know, that there is a positive to be had from that. And in other areas, so the RTT, we are certainly nearer the England average than we were pre-COVID. And certainly regionally and nationally, we've been recognised in our ability to maximise the use of the independent sector to tackle some of those targets and to get a number of our population treated. So I think there's been some really good work by both the commissioners and providers to maximise the opportunity that we've got. But it does reflect, as you say, reflects back to the work that John was talking about the need to try and take every opportunity we can to try and optimise that elective care that you know, the demand that is coming through at the moment.
Yeah, absolutely.
Any questions or comments for Sarah? Okay, thank you. And I think it'll be really interesting to see. There'll be lots of factors that will influence it as the months go by. Certainly the number of referrals going back up to what we would expect rather than the lower levels during the first couple of months of COVID. It'll be interesting to see the impact that they have on some of those indices, but also some of the work that John's doing about
Yep, so very minor changes. So the constitution came to the governing body in January, and the governing body approved the changes, the updates to that. It then has to be sent to NHS England, and in normal times we'd expect a turnaround of 8 weeks, but unfortunately this got caught up in COVID, so it has only just come back to us with some very, very minor amendments as outlined in this paper. So it's come back to governing body just to note those and make sure that you're happy with those suggested amendments, and also to note the timescale for the development of the next version of the constitution, which should be starting usually in September.
Okay, thank you. So we've got a detail of those minor changes that were made to the constitution, and because we've had those changes, we need to approve them. And then also approve the timeline in principle for the next review, which is laid out within the document. Before we come to those decisions, there's I see a few hands have gone up, so let's just take a few questions on this. Simon, first from you.
Just to check, so I don't know whether this might be the document that would eventually go out to member practices, but where you list the member practices, the page doesn't seem to fit in the PDF properly, and there probably is a GP lead that is attached to each of those practices. We would need to get that GP lead correct with each of those practices, wouldn't we?
Yep, so the changes that we've made to the constitution this time were not deemed, so when we discussed it at governing body, deemed not to be significant changes, so they weren't actually anything that needed to go to members for a decision. So the constitution was signed off by governing body, then by NHS England, and as outlined in the paper, we'll get that sent out to each of the practices so that they are updated on what's happened with that. In our next set of changes, it may be that there will be changes that are significant and we need to engage with the members, and we've built that into our timeline.
And I think Simon's point is a formatting one as well as anything else. In that list of practices, it doesn't fit in the page, so if we can just make sure that that is corrected before it gets published on our website or goes to any of our members, please.
Yeah, that's a board packs artifact rather than the document.
Okay, thank you. Judy.
Sorry, I have one question and then one comment. On section 4 about the Remuneration and Workforce Committee, in the red section, this is page 49 of 89 of this document, but the full board. I understood, Glynis was chair, I think, when we discussed it, but Graham is chair now, that we had agreed that it was appropriate for the executive director to be at every meeting, and indeed he has been at every meeting ever since. So I'm just not sure that this red section reflects exactly what we agreed. And it doesn't matter in terms of the formal constitution, but there was quite a long debate about the importance of these subcommittees having somebody from the executive on them so that we were always connected into the latest executive information. And my point of information is that the Primary Care Commissioning Committee, as we are now to be called, is about to receive a paper with 1 or 2 changes proposed for the terms of reference as a result of an internal audit report on the way in which quality of primary care is handled, or the review of quality of primary care is handled by our organisation. Ginny, I'm assuming these things just happen all the way through the year and then once a year you add them. It's not that we have to keep waiting until we've got the final thing.
Yeah, absolutely. So your first question around the exec on the remuneration committee, we have actually added in the sentence that the accountable officer will be invited to all the meetings, will not be a voting member. So that was the addition that we put into there, but it hasn't been highlighted in red, but it is in that terms of reference. In terms of the Primary Care Commissioning Committee terms of reference, yes, in an ideal world, we would sync the processes and all our terms of reference would be reviewed at the same time, and they would all sync with the updates to the Constitution, but it never works out quite like that. So what we'll do is we'll take those changes to the Primary Care Commissioning Committee. If you're happy with them, we'll put those into place, and that will be our effective working arrangement. But we won't update our Constitution until we go through that next iteration.
Okay, is that okay, Judy? Are you happy with that response?
I hear the response, and if the accountable officer or the director of communications and human resources is at every meeting, then that achieves the objective I had. I may have misunderstood what happened since the discussion. Thank you.
Okay. Glynis.
Yeah, I just wanted to check. I'm assuming the Quality Committee and the Finance Committee aren't listed under committees because they're not statutory committees. Is that right?
Yeah, that's correct. The Constitution only requires us to have our statutory committees in there. You can put your other committees in if you want to, but it just means if we make any changes to those terms of reference or membership of those groups, then we have to go through this whole loop with NHS England. So we try to avoid doing that. But the terms of reference of those are included in our governance handbook.
Okay, thanks.
And Andrew.
Yeah, I just wanted to go back to Judy's point, because I agree with Judy. I thought we had changed the Strategic Workforce and Remuneration Committee membership, because I now attend all meetings, so I think that needs to be reflected in there. That was my understanding as well.
And mine too.
Yeah.
Okay. Can we take that? So it may well be that we adjust that and then it gets adopted in the next iteration of the Constitution. But can we take that into the into the next Remuneration Committee, just to make sure that we clarify that and we're comfortable with that it represents where we believe the discussion got to, because the people can always be asked to leave a particular agenda item if there are conflicts of interest, which there may well be if we're talking about executive salaries or an executive remuneration. So let's revisit that within Remuneration Committee if people are comfortable to do that. Okay. So let's do the two decision-making things that we have to do, and I'm just trying to. So first of all, approve the amendments. Again, by exception, people to raise their hands if they have an issue with that. And then to approve the in principle timeline that has been set out, including the action points along the timeline that are within this document for the next review. Okay. Thank you. And sorry, the middle one, which is pending the confirmation that the linked GPs are accurate within the document, which Simon has just asked us to double check, we will then make sure that it is circulated to our member practices as the latest version and be published on our website. Thank you. Anything else for that, Ginny, or is that all you need from us?
No, that's all. Thank you.
Okay. Can I take us then to item 10.1? Can I just do a sense check with people, because we are doing okay for time, and if people want a 5-minute quick refresher, then we can take that, but no more than 5 minutes, or are people happy to press on to the end? Raise a hand for 5 minutes. Judy wants 5 minutes. Okay. Oh, you're muted, Judy, sorry.
I don't need to have 5 minutes if nobody else wants it, but David said yes too.
Okay, so let's take 5 minutes. So 3:33, we'll start the next item at 3:40 by the time we're all back in the room and started again. Okay, let's make a start on the last bit of our agenda. So we're into the committee chairs reports, and we've got those in the locality updates. So let's start with the remuneration committee report. Graham, do you want to start and then hand back to me for the attached paper as and when you are ready?
Yes, absolutely, Chair, and I'll be handing back fairly quickly because I think we can take the report as read. The only things I would want to stress are just to thank Glynis for chairing the committee for the last 12 months. The committee were very appreciative of the way she had done that, and also to reiterate the thanks that you made earlier in the meeting to Simon, but to extend those to the whole of the exec team, to the leadership that they've shown through the COVID crisis. The committee again wanted to record that. But the meat of the discussion was about the ICS lead role and the opportunity to join that role with the accountable officer of the CCG, and your report that's attached covers that with its 3 recommendations.
Thank you, Graham. So the report is there in front of us. I will give a very brief bit of context, and that is that we currently need to find STP leadership for the new year. Philippa Slinger, who is currently in post, remains in post until the end of December. She is prepared to extend that for a short period in order to help a handover, but she has expressed her desire not to stay longer than that, and so that we do need someone taking on that leadership role of the STP. The NHS England have made 3 stipulations around that, and you can see those in item 2.3. The one most relevant to us is that they have stated that they would like to see it combined with the role of accountable officer for the CCG. And as I'm sure you're aware, we currently have an interim accountable officer in Simon Tapley, who is seconded from his substantive post of Chief Operating Officer and Deputy Accountable Officer. So this paper comes to us to consider that proposal. The main recommendation is to consider that proposal of combining the 2 roles. I've articulated in here why I think that is a benefit both to us and to as an organisation, but also to the system, that takes it beyond an NHS England recommendation to something that I believe is in the best interest of the people of Devon. And then, if that is our recommendation, then then to go to recommendations 2 and 3. The second one being to agree the establishment of a system coordination group, which I would chair, and Graham, as our chair of Remuneration Committee, would also be present on, in order to design the process by which we would make this appointment. And then recommendation 3, because it includes the accountable officer of the CCG, that actually a governing body would need to approve that process. So it would come back to governing body either directly or via the remuneration committee, and that route would be determined by governing body. So those are the recommendations, and before we go to those, I will take the opportunity for any questions, anything that people would like to ask. Okay, then I know a number of you had a good chance to look at this paper within the Remuneration Committee when these recommendations were made, so there has been the time to consider that and discuss that. So in which case, what I will do is I will go through, let's do the first recommendations. The recommendation 1 is for us to combine the roles of it'll be the STP lead currently, but at the point at which we become a designated integrated care system, they will take on the ICS lead, but that would be combined with the accountable officer of the CCG. Can I ask for a show of hands for anyone who does not feel able to approve that recommendation? Okay, and that's a unanimous recommendation. So recommendations 2 and 3 kind of go together. So let's take them as a whole. So again, any hands for anyone who feels unable to approve recommendations 2 and 3. So thank you for that. And then the last thing I think it's probably fair to ask governing body is whether the process to whether that you would want that to come back to governing body, or whether that is something you would want to delegate to the Remuneration Committee to review and approve. So, any views on that? So those who would want it to come back to governing body, then in which case, if I can ask you to raise to raise your hands. So we have David, Simon and John have both, and Graham have asked for it to come back to governing body. Okay.
And so have I, Nick, as well.
And Nick. Okay.
I was raising
All
my
right.
hand.
Sorry, am I misunderstanding you, Paul? I thought that was in line with the recommendation. Have I misunderstood you?
So it's whether we need to bring it back to a formal governing body meeting, or whether the governing body wishes to delegate that to the Remuneration Committee. In which case, there are a number of people who would like it to come back to governing body. We can bring it back to governing body. What I would ask is we may well consider, depending on the timing of that, to do that electronically rather than a formal meeting, and then a ratification at the next public governing body. So for expediency, let's do that, but let's involve the whole governing body in that process. Okay. Thank you. In which case that takes us on to the next committee chair's report, which is the Finance Committee. Graham. You're on mute, Graham.
Sorry, that's a payment to charity. We again take this largely as read. The section on quality and performance we've already dealt with as part of Sarah's report at agenda item 8.2. John has covered the financial position in his financial report. You may see that the committee was very reluctant to close down risks, and indeed added a couple of new risks. One of those is just around the sort of temporary financial arrangements that we have, and there is a slight risk that the NHSE might not reimburse all the costs that we're incurring at the moment. So we've added that to the risk register. And then I think the last part was that we had a separate report about the interim financial framework, where we saw that compared to the original budget we set, we're actually receiving more than we might have anticipated through the interim financial framework, which sounds like really good news. But the offsetting bad news is that our monthly rate of expenditure is also rather more than the income we're having. So we've asked John and his team to model the potential year-end projections, building in the discussions we had earlier around savings. Other than that, there's nothing to add.
Thank you very much, Graham. Any questions for Graham on that report? Thank you. Nick, Audit Committee.
I don't have anything to add to the report, I don't think. Happy to take any questions, Chair. Thank you.
Okay, thanks very much, Nick. Any questions for Nick? And then Ginny, just a point of clarity, because I know that we've got the assurance framework and risk register present in that, whether there is a specific ask that you have of governing body for that. Ginny.
Yes, so in the recommendations on the Chair's report, you'll see that you're being presented with the risk management framework, which is our overarching policy on how we manage risk. We've done a few small updates to that this year, largely around how we strengthen our risk management throughout the organisation rather than just at the strategic level, and also some issues around making sure that we're clear on what training is required. So that was approved by the last audit committee, but it's one of the statutory duties of the governing body to sign that off. So that's just come here for approval.
Okay, and we've also got the terms of reference that we need to sign off as well.
So that's you've effectively just already done that through the Constitution, because they're in the Constitution.
Right, okay, that was fine. Okay, so that's already been done. Okay, so any questions or comments about the assurance framework as we've been asked to approve that?
Sorry, it's the risk management framework.
Sorry, apologies, risk management framework.
Yeah.
No, okay. Then can I ask by raise of hands, of exception, anyone who is not able to approve that risk management framework? Then we take that as approved. Thank you very much. Thank you, Nick. Thank you, Ginny. Judy, Primary Care Committee.
Okay, I just wanted to explain one activity for those who weren't there that may have looked a little strange. We wanted to make sure, given how much change had taken place in primary care, that the primary care team, as they moved into their restoration approach, really understood what the needs of practice were. We talked earlier about being supportive to practices. We didn't think it would be very helpful to go out to every practice just at the moment because they are so busy restoring services. And so we undertook an exercise that used the general practice expertise from the Primary Care Committee and from colleagues from the governing body. So I've already thanked them, but a big thank you publicly at the governing body. And what is being developed from this piece of work is the areas in which we need to review our strategy. Joe mentioned earlier it had been approved last December, and areas in which we need to rethink the way in which we provide the support that practices need to operate in our post-COVID world, not just around COVID, but all the other services. Other than that, there's nothing I need to mention.
Thank you, Judy. And can I just say, being part of that conversation, that was a hugely valuable exercise. And it was not just the committee members, but you invited other people who've experienced frontline primary care to contribute. I thought that was a really valuable time. Thank you. Any questions for Judy? Okay. Glynis, Quality Committee. Sorry, Quality Assurance Committee.
Sorry, the thing kept going up and down. Can you hear me?
Yeah.
Yeah, okay. So I've got nothing to add to the report. The only thing I'd highlight is the very last paragraph. It says that we're going to develop a sort of strategy and work plan for the committee, and there's a task and finish group that we've set up. So that's actually not just for the committee, that's for the quality team and for the CCG. So we'll be developing a quality strategy and work plan for the CCG.
Great, thank you, Glynis. And any questions or comments for Glynis on her chair's report? Okay. And then for locality update reports, thank you. I thought these were excellent, and we've got an opportunity now just to go through them. If I can ask the three leads for each locality just to highlight some things from their report, and we'll hopefully have a time for any questions that people have. But first of all, John, Andrew and Charlotte for the Northern report.
Okay, thank you, Chair. So I'll take the report as read. We just had a conversation or a decision around the integrated care system lead and the CCG AO. I do feel that generally, both within those doing the planning and those doing the delivery, there's sort of change fatigue. And so I think as soon as we can give certainty around the function and structure and responsibilities of a local care partnership or an integrated care partnership, as it might be called, the sooner we get that, the better. It's difficult to sort of be standing down services, then standing them up, and then amongst all of that to be redesigning how you do all of that. I think people are a little bit on edge around how this can all work and how we might change our meetings, how we're going to do things, looking at out-of-hospital services, in-hospital services, all these issues. So I think we want to have certainty around these issues as soon as possible, and then allow some very talented individuals in all the localities to get on and manage and deliver that change. So that's what I was going to say, really. I think we need to get surety as soon as possible. And I don't know whether Andrew or Charlotte have anything else to add. Otherwise, open to questions.
Okay.
No.
So James.
Yes, thank you, John. I just wanted to ask about the suicide prevention plan for Devon and North Devon and the wider area. As it mentions, it needs to be stepped back up, but I just wondered if the resources are in place to do that. I know some of the people involved locally with suicide prevention, and one or two of them have been taken away from that work to concentrate on other areas.
Yes, so capacity is always an issue. I have a meeting arranged with Melanie Walker, the CEO of DPT, as soon as she's back from holiday, and that's one of the things on my list to discuss. This is about not only the NHS response, but how businesses and other organizations respond to the ongoing pressures of life, but also the added pressures which have appeared around COVID. So we're doing some work with the Southwest Academic Health Network around how COVID may have affected greatly some disadvantaged groups and made them more disadvantaged. And within that will be trying to get people who are unemployed getting them back to work, or young people who've got no employment getting them back to work, and how their mental health has affected their ability to find employment. So for me, it's not only about suicide, but it is about the wider mental health risks that are very prevalent in our society at the moment. I think we do have things like from the suicide point of view, we have our crisis cafe, which has actually been quite a good success. I can't give you the numbers, but it's been successful. But we do need to spend more time around mental health, and so we haven't had it as a separate work stream. It's actually embedded into both our in-hospital services review and our out-of-hospital services review. So it's really part of everything we do and everything we look at. So direct answer is yes, capacity is potentially an issue, but we need to look across the whole holistic view around how we manage mental health, not just within the health service, but across society.
Thank you.
Thanks, John. I think that's a fair challenge. I know if Jo were here, she would tell you that she has got her team working on what is our strategy around mental health as a commissioner, and that is something that she is expecting to develop and have ready over the next few months. I suspect that would be her assurance for you that actually that she's got the team taking it seriously and trying to be strategic in our approach to how we manage that.
Yeah.
Paul, the STP public health teams also have a strategy for suicide prevention, which is being actively managed, looking at causality in data and working particularly with men, etc., identifying at-risk groups. So there's a lot of work going on there as well. Sorry to butt in, I can't put my hand up.
No, that's absolutely fine. That's absolutely fine, Caroline. That's really helpful. Over to Eastern. So Simon, John, and Glynis.
Yeah, thanks, Paul. So I would support John's view that we kind of need that system strategic direction set for us. We have got, I think now, increasingly collaborative group of providers working together 2 or 3 times a week to meet and discuss where we think the priority should be. And we're focusing, as the detail in the paper describes, around 111 and ED and discharge and care homes. And we've got some themes that we meet on a rotating programme around planned care and urgent care and prevention. We've heard about population health management and the Wave 2 programme that's being piloted in the Woodbury, Exmouth and Budley area. And learning about how they might adapt and change provision in that area according to what they've learned. But I do think we do need, as I said at the beginning of the day, we need a set of outcomes to focus around a direction set by the system strategic commissioner so that we can we can knuckle down and actually focus around those areas and actually work out how we best deliver those outcomes for our patients and for the system. We have set ourselves an ambition to have a developmental day in early September to bring us together. I guess it'll be virtually, but to spend a bit more time together understanding the pressures in primary care and in secondary care. And I think a large amount of the work we're doing is really just developing those trusting relationships so that we can move forward together and we can start to put more challenge to each other, perhaps was initially possible. We've got colleagues now from several sectors of the RD&E, clinical side and management side, social care, mental health, who attend increasingly regularly, and 3 different sectors of the Eastern locality primary care, as well as commissioning from the local authority and from the CCG. So it's quite an inclusive group, developing those relationships that are so important to be able to make those changes. But I think we need what we need is the time and the direction from the system to make us focus on the things that will really make the difference. But any questions on the detail in the paper, I'm happy to take those as best I can, or take them back to the team.
Thanks. Thanks, Simon. And I think because obviously, people who may be watching this as our public meeting won't be aware that we prior to this meeting, we did some workshop, some development work as a governing body, looking at what our priorities should be as a system strategic commissioner, and hopefully that will provide the output of that will provide some clarity and will give you, certainly in those local areas, a little bit more of a more solid framework to work within. So I think that reflects back to that conversation that we had earlier, the importance of it. Thank you. Anything for Simon? Okay, so Western, Sheila's on leave and so not at the meeting this week, and Joe has had to go to another meeting. So Nick, the remaining member of the Western team, is there anything you would like to highlight in the report? You're just on mute, Nick.
I'm not doing very well today.
Oh, there we go. There we go.
So I'd like to pick out 5 things from the report, if I may. The first is the success of the connectivity that's gone on during the COVID period, particularly the weekly system-wide video conference that's brought all of the key players together in the West, has been very successful. Then in terms of the key priorities for the next 3 months, there is a particular focus on investigating whether or not we can use the fair shares funding, which the CCG discussed at length just before Christmas. Seems like a lifetime ago now, doesn't it? And the Western system is looking at how we can use the fair shares funding to substantiate some of the changes that have been developed through COVID, to try and put them in on a more sustainable basis. So I think that'd be a really good use of the fair shares funding, I think. 2 risk issues that I bring the board's attention to. 1, workforce, particularly in the voluntary sector. There's a big issue there because of the impact of COVID, and it remains to be seen whether or not that recovers quickly. And also the resilience of Plymstock GP practices, following on from the Barton surgery contract, which everyone is aware of, is still not completely resolved. And then finally, in terms of support from the CCG required, the progression of the ICP, bringing it forward to December, would really ease the pressure on the system over the winter if we can get that ICP contract up and running by December, which is a huge challenge that Simon has set Sonia, who's now the SRO for that project, but she's driving it really hard. So hopefully we'll be bringing something to the board in August to provide more detail on that. I'll take anyone's questions. Thank you, Chair.
Okay, thank you very much, Nick. Any questions for Nick on that? I think those are some very well-made points very relevant to some of that earlier conversation that we've had. Okay, so David and Judy, the South report.
Thank you. It's actually very refreshing to be doing a report that's not entirely about COVID. Most of what's written here is about the phase 2 recovery and restoration plan. And it's very good to be hearing about pieces of work that relate to things like the Diabetes Improvement Group, the Respiratory Steering Group. These are all things that are really trying to improve the way that we look after particular chronic conditions that I think have sort of felt forgotten over the last 6 months. And in terms of getting people out of hospital, the Home First group is doing some great work. And there's also the Frailty Partnership group, which is working with the Home First group. So we're sort of back to real normal work, and I'm finding that quite encouraging. Key priorities going forward, obviously the winter planning, diagnostics, elective care and digital are all up there in our priorities. I think Simon's already mentioned it, but Newton Abbott's also part of the population health management pilot, and we're waiting to see early outcomes from that. I don't think I've got anything else hugely to say, but happy to take any questions. Unless Judy's got anything else she wanted to add.
No, nothing to add.
Okay, so any questions for David? Nick Kennedy.
Yeah, hi David, thank you. Just interested in the thing about with the emergency care intensive support team, the care coordination concept that that's being done. Can you give us a little bit more information on that?
I'm not sure I'm the best person to answer that. I will find out for you.
Thank you. It just seems like an interesting idea.
If you like. So it's a project which ESIS are hoping to get people to take as a pilot for actually directing people directly to community services rather than through the acute sector and then coming out again. And it's talking about how to set that up, and there's a variety of models. There's a lot of work to go on it before it's something that you can actually implement locally, but that's essentially what it is.
Thank you.
Great, thanks. Graham.
Thank you. John, there's a piece right at the end of the report where you say that you're hoping to be able to restrict ED attendances to 80% of what was happening previously. I think in a report, it was the John Finn report we heard earlier, that attendances are already at 90% of what they were. So what do you think the plans might be to try to effect that aim?
Is that for me? I think one of the key things is the Home First, which we've just been hearing about trying to direct acute care away from A&E. Hopefully the 111 first will have an effect, and hopefully the Home First project will be effective as well. And also the Frailty Partnership, which is looking at how we deal with the very frail to keep them away from hospital, if at all possible. So I suppose those are the main things that are in our plans.
Thank you, David. I should have said David, not John, previously. It would be good to get reports back on that, and just to see, how more widely we might apply those across Devon.
Yeah. Penny. Sorry, Penny, you're on mute.
Eventually. Sorry, I missed the question. I got a question coming in on a phone. Sorry.
No, sorry, you had your hand up, Penny.
Oh, sorry, I put it down. It was the ESIS thing. Sorry.
Oh, fine. Okay. All right. Thank you. And then I've not got any other questions coming up, in which case, at 4:10 on a very sunny Thursday afternoon, I would like to thank you all. I think it's been a hugely productive day. We've covered a lot of things and a lot of really useful things for the governing body. So let's call that meeting to an end. That's the end of our public meeting. Thank you for attending. Thank you for those who have listened, and have a very pleasant evening. Take care.